Hello and welcome to this session. We are looking at pancreatitis. Pancreatitis, when you see the itis, you know it's an inflammation. So it is the inflammation of the pancreas. So the pancreas, we are saying it's the pancreatitis is inflammation of the pancreas. Okay, it normally ranges from just being mild to a life-threatening condition. Okay, that must be treated with Dr. ABCD. Okay, so it occurs in acute or chronic forms with 10 to 30% mortality rate in acute form. Okay, it produces irreversible tissue damage with chronic form, which tends to progress to significant loss of pancreatic function. Possibly it's idiopathic with unknown causes, but sometimes it's associated with biliary tract disease, alcoholism, obesity, trauma, and certain drugs that we are going to mention. So when you look at the pancreas, you can see the borders, gallbladder, yeah, cystic duct. It joins with the common hepatic duct. Okay, then you have common bile duct, and then it empties its secretions to the duodenum. Okay, to the duodenum. Okay, guys, so the pancreas, you can be able to see it. The pancreatic duct, you can also be able to see it, bringing all the secretions to the duodenum. Yeah, and then the spleen. So what is the main function of the pancreas? We are saying that the main function of the pancreas is to maintain healthy blood sugar levels. So it produces insulin and glucagon and other hormones. You know, diabetes will occur if the pancreas will not be able to secrete insulin, especially the insulin resistance diabetes. Okay, yes. So the exact trigger or mechanisms that normally initiates enzyme activation is unknown. So common bile duct blockage, duct, common bile duct. This one, guys, yeah, common bile duct blockage leads to reflux of juices back into the pancreas. Yeah, back into the pancreas after initial release. Okay, so guys, this pancreas will release some enzymes that will be very important when they are released at the duodenum to aid in digestion. Okay, so in the case of blockage, these enzymes will not be able to get to the duodenum. Instead, they start digesting the pancreas itself. Yeah, auto autophagocytosis. Yeah, yes. So we have acute pancreatitis and chronic pancreatitis. So you're saying that in this case, we have enzymes normally excreted into the abdomen by the pancreas are activated in the pancreas and its duct and start to auto-digest pancreatic tissues. Okay, so we have auto-digestion. Okay, so consequently, inflammation causes intense pain. We have third spacing of large fluid volumes, pancreatic fat necrosis with consumption of serum calcium and occasionally hemorrhage. On the other hand, when you look at chronic pancreatitis, we are saying that this one results from progressive inflammatory changes, which normally leads to permanent structural damage. The exocrine and endocrine function of the pancreas are disrupted. As a result, we have fibrosis, okay? We have fibrosis and reduced function. And you'll find that the major cause of chronic pancreatitis is ethanol or alcohol consumption, whereas the major cause of acute pancreatitis is gallstones. Look at, for example, this pancreas. Yeah, you can be able to appreciate the movements of food getting into the pyloric sphincter. Then it can get to the duodenum where it's able to get secretions from the gallbladder and the pancreas, right? Yes, so we have something called the duodenal papilla there. Yes, so But in a case where the pancreas is damaged, you're able to appreciate the cell damage and tissue damage, yeah, excessive redness these places, and fibrosis at one point, okay? When you look at causes of acute pancreatitis, we have already mentioned that the major cause of acute pancreatitis is gallstones. They are normally trapped at the ampulla of Vater. Ampulla of Vater, yeah? Ampulla of Vater. And this one mainly affects women and elderly patients, okay? Women and elderly patients. We also have ethanol. Alcohol is abused, for the role of alcohol is that it directly destroys or is directly toxic to cells, and when the cells are destroyed automatically, it leads to inflammation. You find that this one is more common in men and young patients, okay? And young patients. We have a number of causes of pancreatitis, but we can have a mnemonic where we are saying I get smashed, where I stands for idiopathic causes, G stands for gallstones, the main cause of acute pancreatitis, E stands for ethanol or alcohol, the main cause of chronic pancreatitis. Then you have trauma, yeah, penetrating abdominal trauma, or even a scorpion sting can result or can initiate the process of inflammation in the pancreas. We also have steroid use, excessive steroid use, mumps, infections like mumps, autoimmune diseases, scorpion stings, hypercalcemia, hypertriglyceridemia, endoscopic retrograde cholangiopancreatography, ERSP, could lead to a complication that results in inflammation of the pancreas. And lastly, drugs or medications. And these drugs and medication, the notorious ones, could include Lasix, okay? Lasix, didanosone, and pentamidine, okay? Sulfonamides have also been implicated in this case, okay? So guys, those are some of the major causes of pancreatitis. Looking at risk factors, smoking, obesity, biliary cyst, abnormal organ structure, familial history, same to chronic pancreatitis. These are the major risk factors for developing inflammation in the pancreas. What about incidence? They're saying that acute pancreatitis occurs in more than 200,000 people each year. So that you have chronic pancreatitis only occurs in 87,000. So from the statistics, you can be able to see acute occurs more common than chronic. Then you're saying that acute and chronic pancreatitis are slightly more common in adult males than adult females. And this is because of the risky behaviors that men do engage. Like you expect them to find them, majority of them smoking, majority of them abusing alcohol, majority of them being involved in injurious or risky sports that can easily result to trauma. Okay, thank you. Acute pancreatitis can occur in any age. Chronic pancreatitis commonly affects those older than 45 years. Complication you're saying it could result into diabetes mellitus, when the pancreas is no longer secreting insulin, so yeah, glucose will not be taken to cells, so hyperglycemia is going to result. High diabetes mellitus might might develop. The other conditions, you have massive hemorrhage, shock, coma, acute respiratory distress syndrome, atelectasis and pleural effusion, pneumonia, paralytic ileus, GI bleeding or obstruction, pancreatic abscess and cancer, chronic pancreatitis, malnutrition, Pseudocysts. This pseudocyst, we are talking of the collection of pancreatic juice, yeah? Collection of pancreatic juice, because there's blockage, the pancreatic juice are not able to get into the duodenum, so there's collection of that pancreatic juice. We call it, they form pseudocysts. We also have acute kidney injury, and lastly, the one that is feared most, death. When you look at assessment, we can have history and physical findings. In history, we are saying the patient may complain of nausea, vomiting. You need to identify the predisposing factor for this case, okay? You need to rule out the history of alcohol, cigarette smoking, heavy drug use, okay? Patient could present with myalgia and arthralgia. When you talk specifically of acute pancreatitis, we're saying that here we normally have sudden, steady, intense epigastric pain centered close to the umbilicus and radiating to the back. That's between 10th thoracic and 6th lumbar vertebrae, and normally lessens when leaning forward. Pain is aggravated by consuming fat foods or alcohol, walking or lying down, and relieved by sitting up or leaning forward. Then patients could also report of bloating and diarrhea. What of chronic pancreatitis? Will have intermittent or constant dull, severe pain in the mid to upper left abdomen, possibly radiating to the back and lasting for several hours. Pain aggravated by consuming fatty foods or alcohol, weight loss, and steatorrhea, yeah, fats in feces. We have physical findings. As the healthcare provider, you may find that this patient is hypotensive, this patient is having tachycardia, fever, dyspnea and orthopnea, basilar crackles, pale complexion, diaphoresis, confusion, pleural effusion, generalized jaundice, hypoactive bowel sounds. We could have some distinct signs that you really need to know, like the Cullen sign. This is normally the bluish peri-umbilical discoloration, Cullen sign. Then you have the Turner sign. This is the bluish flank discoloration, okay? Lastly, we have abdominal tenderness, distension, rigidity, and guarding. On laboratory test results, yeah, we could start with on diagnostic test, yeah, so that we start with laboratory. In acute pancreatitis, we have amylase, serum amylase test, and lipase test are elevated, almost 3 times the normal. When you do CBC, we'll have white blood cell count and differential is elevated. Hematocrit may also be elevated. Bilirubin test results are elevated. We have transient hyperglycemia and glycosuria are present. C-reactive protein results are elevated. It's good to know that C-reactive protein is a marker of inflammation, although not specific, okay? There are so many conditions that may result in elevated C-reactive protein tests, okay? Amylase urine level tests are increased, okay? The urine levels for amylase will be increased. You also have serum alanine aminotransferase level test and aspartate aminotransferase level test, and lastly alkaline phosphatase level tests results are mildly elevated, especially when alcoholic hepatitis or choledolithiasis is present. What about chronic pancreatitis? We're saying that here we have serum alkaline phosphatase level and bilirubin test may be elevated. Amylase, that is the serum level, and lipase may be normal or decreased. Serum glucose test results are transiently elevated. Lipid and trypsin levels in stool are elevated. The CBC with differential is normal. From laboratory, we go to imaging. And you're saying that in imaging, abdominal and chest radiography differentiate pancreatitis from other diseases causing similar symptoms. They may also detect pleural effusion. Computed tomography scanning, that is abdomen and pelvis, and ultrasonography, of the pancreas, will show increased pancreatic diameter, pancreatic calcification, pancreatic cysts, and pseudocysts. When you do an MRI, magnetic resonance imaging, it may show abnormalities in the pancreas, the gallbladder, or bile, or the bile ducts. From imaging, you go to diagnostic procedures, and you're saying that endoscopic retrograde cholangiopancreatography shows pancreatic anatomy, identifies ductal system abnormalities, and differentiates pancreatitis from other disorders. Those are diagnostic test results. So, in Glasgow score, we are saying we are looking at the signs and symptoms of pancreatitis, and we are trying to assess the severity of this condition, whereby a score of 0 to 1 will be termed as pancreatitis, a score of 2 will be termed as mild, okay, a score of 3, severe pancreatitis. And then, so that this scale, we are saying we normally is summarized with the mnemonic pancreas, which has 8 criteria, and there is usually 1 mark for each criteria, okay? So, like the first P stands for partial pressure of oxygen. It's usually less than 8. Age, greater than 55. Neutrophils, this is part of the white BCs, they should be greater than 15. Calcium should be less than 2. R for urea, that should be greater than 16. E is for enzymes, especially the LDH, yes, it should be greater than 600. Or ALT greater than 200. Albumin should be greater than 10. Then the glucose should be greater than 10. If you get any of these criteria, you're going to give it 1 mark each, so that if it is just 0 to 1, mild pancreatitis. If just 2, moderate pancreatitis. If it's 3 plus, you would say that that is severe pancreatitis. Treatment. In treatment, we're saying you have general treatment, diet treatment, activity treatment, medication treatment, and surgery kind of treatment. When you start with general, we are saying that this is an emergency treatment. It requires emergency treatment of shock as needed. And we're saying we are going to use Dr. ABC in this case. We may require blood transfusion, especially when there is hemorrhage. Okay, nasogastric sanctioning, and VTE prophylaxis is required. In terms of diet, we have NPO, initially to allow the pancreas to recover. Then have, once abdominal pain starts to resolve, low fat, low protein diet with avoidance of spicy foods, which may stimulate pancreas, is initiated. Okay. Total parenteral nutrition if the patient cannot tolerate oral intake at all. Then we urge for alcohol and caffeine abstain. You abstain, okay? What about activity? We're saying activity as tolerated by the patient. In terms of medication, we are saying we start with acute pancreatitis. You can give IV fluids for hydration, analgesics for pain management, antibiotics, yes, for acute, electrolyte replacement as indicated, and we may need supplemental oxygen as appropriate. Remember, you're using Dr. ABC in that manner. For chronic pancreatitis, we may still need analgesics for pain, okay? And then we may need pancreatic enzyme supplements because they are no longer being produced, yes? We may need octreotide acetate to reduce exocrine secretion, medium chain triglycerides for fat malabsorption, fat soluble vitamin supplementation, insulin therapy to address glucose intolerance for chronic pancreatitis. In terms of surgery, you're saying that not indicated in acute pancreatitis unless there are complications occur or gallstones are the cause, okay, in which in this case the cholecystectomy will be indicated. So for chronic pancreatitis, we have sphincterectomy, duct drainage, or pancreatectomy, okay? So pancreatic jejunostomy will also be implicated as one of the surgical intervention, or endoscopic or percutaneous aspiration of pseudocysts, yeah, when asymptomatic or larger than 7 centimeters. Nursing consideration, we're saying that you need to screen for and assess patients' pain using the facility approved criteria that takes into consideration patient's age, condition, and ability to understand. You also need to treat the patient's pain as needed and ordered using non-pharms such as the distraction, imagery, progression, muscle relaxation, pharmacologically, or a combination of the two approaches. You closely monitor a patient who is prescribed opioid treatment and is identified as being at risk for adverse outcomes. Remember to assess and respond to patients' pain by evaluating the response to treatment and progress towards pain management goals. You give IV fluids therapy as ordered. Make sure the IV access is patent. Administer pancreatic enzyme replacements with meals, especially in the chronic pancreatitis. Obtain finger glucose, blood glucose levels, and administer insulin as ordered. And this is still in the chronic form. Encourage the patient to express feelings and concerns. Provide emotional support in both forms. Yeah. You maintain NPO status until pain and tenderness resolve and GIT motility returns. Assess the insertion of or insert an nasogastric tube for decompression. Provide NG tube care. Maintain NG suction as ordered and observe the characteristics of NG tube drainage and report in case of abnormalities. You need to administer enteral or parenteral nutrition as ordered. So when oral intake is allowed, provide small frequent meals advance as diet is tolerated. Okay. Obtain daily weight. Insert indwelling urinary catheter if indicated to evaluate urine output and kidney function. Monitor hourly urine output. Okay. This is especially in the acute pancreatitis. Position the patients with the head of the bed elevated to ease the work of breathing. Ensure coughing and diaphragmatic breathing exercises and incentive spirometry have been initiated, especially after the surgical interventions. Administer supplemental oxygen as indicated by oxygen saturation via pulse oximeter, yeah, especially in the acute case. Turn and reposition the patients regularly, frequently, unless contraindicated. Base the frequency of repositioning on the patient's tissue tolerance, skin condition, mobility, medical conditions, and treatment goals. Apply anti-embolism or sequential compression stockings to prevent VTE. Okay. Obtain specimen for laboratory testing to evaluate pancreatic enzyme levels, glucose levels, overall fluid and electrolyte status. Prepare a patient with chronic pancreatitis, including the family or the caregiver where appropriate, for the possible surgery. What are you supposed to monitor as the registered nurse? The registered nurse should look at the vital signs, NG tube function and drainage, respiratory status of the patient, acid-base balance, serum glucose level, the amylase and lipase levels, fluid and electrolyte balance, daily weight, pain level and effectiveness of the intervention that have been put up, nutritional status and metabolic requirements, kidney function, and post-operative status as appropriate. What are some of the activities that the registered nurse will partake for this patient? Registered nurse will be involved in alignment and pressure reducing device application, in anti-embolism stocking application, in blood glucose monitoring, in incentive spirometry measurement and use, in applying or inserting the indwelling urinary catheter, in calculating the input and output measurements, in the nasogastric or orogastric insertion, irrigation, monitoring and removal. The registered nurse will also be involved in assisting in nutritional screening, in administering oxygen as ordered. The registered nurse will also be involved in pain assessment, management, also the pressure injury prevention, relaxation and stress management techniques. The registered nurse will also apply safe medication administration practices, will also help to apply the sequential compression therapy, stool specimen collection, surgical wound dressing application, and lastly, wound assessment. What will be the patient teaching? We're saying that you need to include the patient's family or caregiver in your teaching when appropriate. Provide information according to the individual's communication and learning needs. And make sure you are talking about the disorder, possible underlying causes, diagnostic tests, treatment, including the need for IV fluids, NPO status, and pain control as appropriate. You also need to talk about pain management plan, potential adverse effects of pain management treatment. Also look at safe use, storage, and disposal of opioids if prescribed. Identification and avoidance of acute pancreatitis triggers. Yeah. Dietary needs, including small, frequent meals that are high in carbohydrates but low in fat and protein, especially for this is for the acute pancreatitis, or small, low protein, high calories meals for chronic pancreatitis, and other appropriate food choices. Also talk about the signs and symptoms of pancreatitis recurrence and need to notify the physician immediately if they occur. Prescribed drug therapy such as pancreatic enzyme supplements as treatment for chronic pancreatitis, and the need to take pancreatic enzymes before or with meals and snacks. Technique for insulin administration if appropriate, especially for patients with chronic pancreatitis who now have diabetes mellitus as a complication. Importance of abstaining from alcohol, especially for chronic pancreatitis, and need for smoke cessation. Okay. We also need to look at the need for continued follow-up, including laboratory testing to evaluate the effectiveness of the therapy. Okay. What about the discharge plan? Remember, as as nurses, we participate in the discharge planning and always include the patient, okay, and other cadres. So you determine the appropriate post-hospital setting to which this patient should be discharged to. Is it at home, nursing home? You need to assess the patient's and family understanding of the diagnosis, treatment, prognosis, follow-up, and warning signs of which and when to seek medical attention. Identify the patient's formal and informal support. You identify the patient's and family goals, preferences, comprehension, and concerns about discharge. You need to provide a list of the prescribed drugs, including the dosage, prescribed time schedules, and adverse reactions to be reported to the physician. Provide the patient and the family, where appropriate, with written information on the medication that the patient should take after discharge. The nurse needs also to assess the patient's and the family understanding of each prescribed medication, including the dosage, administration, expected result, duration, and possible adverse effects. Lastly, the nurse needs also to assess the patient's ability to obtain medications. Identify a party responsible for obtaining medication. If a challenge, the medical social work needs to be brought on board to assist where necessary. You also need to instruct the patient to provide a list of medication to the physician who will be taking care of this patient after the discharge. The patient needs to be reminded to always update information with the physician when he discontinues any drug, when he changes any dose, and when he adds new drugs, even the over-the-counter drugs. And should be able to remember to carry a medication list that contains all this information at all times in the event of an emergency. You also need to ensure that the home health care has been arranged as indicated. Provide information on smoking and alcohol cessation. Ensure the patient and the caregiver receive contact information for medical support. Provide contact information for local support groups and services. Ensure that the patient or caregiver receives a copy of discharge instruction and that a copy is placed in the patient's medical record. Remember to document the discharge plan evaluation in the patient clinical record, including who was involved in the discharge planning and teaching, the understanding of the teaching provided, and any need for follow-up teaching. So guys, I have a patient here who has developed chronic pancreatitis. What will be the appropriate home diet for such a client with chronic pancreatitis? I'm giving you 1 minute. Is it a low protein, high fiber diet distributed over 4 to 5 moderate sized meals daily? Is it a low fat, bland diet distributed over 5 to 6 meals daily? Is it a high calcium soft diet distributed over 3 meals and an evening snack daily? Or a diabetic exchange diet distributed over 3 meals and 2 snacks daily? Yes, it should be low diets. Should it be high fiber? Oh, high fiber is going to take a lot of time and this is going to result into more problems, okay? So a low fat diet, a low fat bland diet prevents stimulation of the pancreas. We don't want to stimulate the pancreas anymore while providing adequate nutrition. When you look at dietary protein and fiber, they are not directly related to pancreatitis. Although calcium is important, the low fat content is more significant. The hyperglycemia of acute pancreatitis is usually transient and does not require long-term dietary modification. A client has been hospitalized. A client has been hospitalized with pancreatitis for 3 days. The nurse assesses the client and documents the accompanying results. The nurse realizes that these findings are a manifestation of pancreatitis, guys. CNS, calcium, yeah. Cullen sign, yeah. Kelensign we talked is at it as one of the major clinical manifestation of pancreatitis. In short, guys, we can be able to differentiate between acute pancreatitis and chronic pancreatitis. Acute pancreatitis results in auto digestion of the pancreas. The pancreas eating itself because of the enzymes that have been released and they are not getting to the right place, so they start digesting the very pancreas. Whereas chronic pancreatitis, we are saying that there is structural changes. We are having fibrosis and it's mostly related to what? Alcohol. We can say that acute pancreatitis is an acute and unisolated episode. Okay, this is chronic and ongoing disease. We have active inflammation here. We have chronic changes and damage that are coming up as a result of the condition. Acute pancreatitis is sudden and severe. Okay, when you compare with the chronic, symptoms do fluctuate. So this is a short term, long term, could take days to weeks. This one could take months to years. When you look at enzymes, we have fear that we say that enzymes are elevated pancreatic enzymes, leading to autodigestion. Here the enzymes may be normal or reduced because of those structural changes. So the cells might not be producing the normal secretions, okay? Common causes we have talked of gallstones as the major one and alcohol. Common causes here we have recurrent acute episodes, alcohol, hereditary, and other diseases. Okay? Okay, guys. So thank you so much for creating time for this video. It has been a pleasure taking you through pancreatitis. Until we meet again, goodbye from me. Hi, hi.